Hi guys, welcome back for another talk here at IAFNR. My name is Dr. Michael Longier. For those of you guys that don't know me, I sit on the board of IAFNR, and Dr. Janice and Dr. Gia have done a phenomenal job in putting this together and had me speak again this year. Um, for those of you guys that don't know me, I practice in Jacksonville, Florida now with my wife, and we see a lot of interesting cases, to say the least, from a neurological perspective, but also from a neuro-emotional perspective as well. We do a lot of NET, neuro-emotional technique in the office, or she does most of that. I do most of the neuroplastic therapies and things along that line. I used to and still am affiliated with Life University as well. We work with the research department on some projects around looking at what chiropractic does to the brain and how neuroscience and neuroplastic change affects different health conditions. And what I want to talk to you guys about today is something that really we've seen for a while in our offices. And I think you guys have probably seen this too, but something we're definitely seeing a lot more of. And I'm down here in Jacksonville, Florida, so we're next to the Mayo Clinic. Like I could throw a rock and hit some of their offices from here. And even they don't know what to do. They're finally starting to recognize this link with autonomics, something that's kind of generally referred to as dysautonomia, but we'll talk about it under the name of POTS, long COVID and concussion, and really how these things link up and why they link up and what parts of the brain are involved in this. And so as we kind of dive into this topic, I just want to share just some similarities that I've seen between these patient bases and then shed a light on why I think that is. And then at the end, I'll give you guys kind of a protocol of what we've been doing here to help and get some changes in them and really work with this patient base, because this is something that is exploding as far as the population goes. There are tons of people that fall into this. Concussion's been in the news for a long time now. If back to when Junior Seau first really shined a light on it, so to speak, with his suicide and paying attention to that. And for those of you guys that work in the realm of concussion, I think you understand that the brainstem and the traction axonopathies and the stretching and shearing that happens and why it affects the autonomic nervous system and the different symptoms that we see, from light sensitivity to high heart rate and those kind of things. Well, POTS and dysautonomia fits right square in that, right? So concussion can cause like a POTS or a dysautonomic type of presentation. And now what we're seeing with this post-COVID world or after COVID now is long COVID kind of acts the same way. And you're seeing some similarities with brain injury and what you see neurochemically with that and POTS and long COVID. And you're seeing some similarities or some difficulties in patients that now suffer a concussive injury if they already had POTS or now in this post-COVID world too. I feel like what we're seeing, and I'll share a case with you guys of a young man that's in our office right now that his symptoms are a little bit different than what I think he might have normally had with a concussion. Back in the day, it was most of the autonomic stuff, the POTS and dysautonomia things were seen more in the female population, but post-COVID now we're seeing it more in the males as well. So, and again, we can put our tinfoil hats on and point our fingers at all sorts of reasons or causes for some of those things, but the reality is we're seeing it, and now how do we unwind it? How do we deal with that piece, right? So we'll kind of jump right in here because these are some terms, right? I want to define a few of them at least. First is the autonomic nervous system and that autonomic balance. I think we all get in school enough of the fight or flight, rest and digest, sympathetic, parasympathetic. Something that I want to bring to the forefront, though, is this idea of autonomic balance. A lot of times we talk about balance in a system and we kind of assume 50-50, right? That's not how your autonomic nervous system should work. It should be nowhere near 50-50. I think in a lot of cases in our society right now, a lot of people are functioning around that 50-50, but that's not a healthy place to be. It really should be in this 80-20 range, meaning we should be parasympathetic or in that rest, digest, and rebuild state 80% of the time, and we should be in that fight or flight or excited state 20% of the time. And when we get out of balance, that really starts to erode the system in general. So if you think about the area where our pneumotactic centers and our cardiopulmonary centers are, they're in our brainstem, in the caudal medulla and in the pons, right? So when we look at if those two areas get dysregulated by being in that 50-50, there's a large breadth of effect that is changed or altered through that, because every signal going from the brain to the body or from the body to the brain travels through those areas. So when we change the frequency of firing or the central integrated state or the overall pool of activity in that bank of neurons, it can have a systemic effect on a lot of different things. And it can affect a wide range of things throughout the body. And that's why I think we're seeing what we're seeing with some of the long COVID cases, with some of the dysautonomia slash POTS, and concussion as well. Right. So when we take those three cases, I think we're seeing a lot of things. I think Dr. Berger is doing a talk this time around on whether or not we would consider long COVID a traumatic brain injury. And I personally absolutely would. I love that thought process. I think that it plays, when you look at what happens in the mechanical aspect of a head injury, especially like we said, when you have a whiplash or a concussion, it's not just the brain smashing up against the skull, which oftentimes will cause issues with frontotemporal poles and some other areas. But it's also, you've got this heavy gelatinous blob sitting on top of a thin stalk, right? Your brainstem and your spinal cord, if you will. And when that blob gets going and the brainstem doesn't, it's going to start to traction things. And the breaking point seems to be like the hypothalamus. And there's actually a condition or a physiology known as hypothalamic shearing that occurs, and it's the understanding of why we have so many of these changes in the body. Because if you have hypothalamus sheared or affected, not only are you getting brainstem changes, but you're also now, and you're getting like wiring changes, right? So electromechanical forces traveling up and down the axons, but you're also getting, neurochemical changes, because the hypothalamus is the seat of that endocrine system. So through hypothalamic pituitary integration is how you're sending your chemical messengers throughout the body too. So now you can alter hormonal regulation. And so you've really just open up a whole can of worms when you add a concussion to maybe an already fragile autonomic nervous system. So concussion really plays in that. But now what we're seeing with long COVID is where it kind of hangs out, or how it hangs out in the system. It's creating some neurometabolic changes that are very similar to that of a head injury or of a concussion. And I think because of where we're seeing that virus or whatever the spike protein hang out in the system is why it's wreaking havoc and causing some of that. But when you look at this balance, just the perspective of balance, that 80-20 rule is where we really need our patients to be healthy. And if you think about, breath really tells us where our function should be and what that balance should be. We look at breaths per minute, and I know there's medical norms, 12 to 20 or whatever. 12 to 20 is actually a lot of breaths per minute. That's a pretty rapid breathing rate. An optimal breathing rate for your nervous system at rest. Again, this isn't, maybe while I'm sitting here doing this talk, I shouldn't be at 6 breaths per minute, but an optimal autonomic breathing rate is about 6 breaths per minute. And when you think about this, I know when I took the Carrick modules, one of the things that we talked about was 3 seconds in, 6 seconds out. I think Brandon Brock was the first one to really bring that to my attention. And so when you breathe in, that's a sympathetic activation. When you breathe out, that's a parasympathetic. So if you look at 6 breaths a minute, which would be that 3-6 breath, twice as long out as you breathe in, that's starting to put you in that balance. So we use something in our office called pranayama breathing, just to focus people's autonomics. I'm not a huge fan of breathing exercises long term, but we do some things like Wim Hof or pranayama just to reset balance while we're doing some therapies with people. And if you focus on that 3 in, 6 out, that gets us closer to that 80-20 balance of autonomic function. But a lot of your patients, if they're at 12 to 14 breaths a minute just at rest, they're probably going to be more of a 1 second in, like 2 seconds in, 2 seconds out, or a 1 and 1, or 1.5, 1.5, which is going to be more 50-50 in that autonomic balance. So just the breathing that your patient is doing off the bat in the beginning of the exam, the rapidness of the respirations and the balance of the breath in and breath out will give you a really good indication as to what your patient's autonomic balance is. And if they fall into this dysautonomia POTS umbrella off the bat. It's kind of, most cases of POTS and dysautonomia, at least before COVID, were females. And so our rule's always been, females have a form of dysautonomia or POTS until proven otherwise. And when you see the respirations and the breath and the scalenes are really tight, now you really can start to understand that. And so with all of our patients for a long time, I've kind of treated their autonomic nervous system off the bat for most of their conditions and had a good result with that. So that's going to be what we show as far as what our patient protocols are here with this lecture too. But, always kind of keeping in sight that idea of autonomic balance and really not balance as it is like 50-50, but more that 80-20 rule. And you'll never get anybody to 80-20. Our society just doesn't allow that. But if we can strive for that, I think that's where we need to be. So again, first, just kind of defining a few terms here. What is dysautonomia? This is just a quick Google search. I'm sure this is AI or something at this point, giving us these definitions. But dysautonomia is a condition that affects the autonomic nervous system. All the hallmarks: dizziness when standing up, rapid heart rate when you're standing, or even really slow or bradycardic heart rate. So your patient that is, I use this example because it was a patient in our office. She was 65, she was overweight, and her resting heart rate was 63. That's bradycardic, in my opinion. Her body type, her physical activity level, her heart rate never really should have been 63, right? So if you see a heart rate that doesn't fit the patient, in the same vein, you see a slender 15, 16-year-old female whose resting heart rate is 85, even though it fits in that 60 to 100 window, right? It doesn't fit the patient that's standing in front of you or sitting in front of you. Make sure that your little, your red flags or your spider sense is going up around that. Sweating is another big one. I'm down here in Florida where we sweat like 9 months out of the year. If you have patients that come in, and that's one of the questions I ask them, or it's at least something that I even observe, if they don't sweat, that's an issue. That's how your body relieves toxins. So if they're not sweating, they could not have dizziness, or, maybe their heart rate just teeters around 80. But when they're not sweating, they can't detoxify. And it's showing that that autonomic nervous system is not activating in the way that it's supposed to. And then you see a whole host of things, right? If you look, gastrointestinal issues, vision problems, I'm not going to read the slide to you guys, cognitive problems, anxiety, fatigue, all of those things, they fit under this umbrella. I kind of look at dysautonomia like I would look at, say, a lupus diagnosis back in the day. If it didn't fit under something, they're going to call it dysautonomia. And that's what we're seeing with a lot of our, again, we're right next door to Mayo. So a lot of our patients, have gone to Mayo. They have this list of symptoms. They kind of call it dysautonomia or POTS, and then they kind of tell them to move on. They don't really have a treatment protocol. I'll go through what the standard treatment is, but it's not really treatment as much as it is they hand them a pamphlet and say, try this. And so we need to be better. We need to be that bridge, because we can help these patients a lot, and we can help these patients in a really short amount of time. And when you get good at these cases, or recognizing them and knowing what to call it and how to treat it, you can fill your office with these. We have the one patient I'll share with you guys. I think her alone put us on a waiting list just after we helped her. So, these patients, they're all over the place. They need a lot of help because they're not getting it anywhere else. So this idea of dysautonomia, or a breakdown in the autonomic nervous system, you might argue that in this day and age, long COVID or post-COVID, that everybody has some dysautonomia. Now it's just a matter of whether or not it affects their life to a level that changes their activities of daily living or affects their quality of life, right? It's kind of like, if you've ever read the DSM-5, which is the psychiatric handbook of diseases and things like that. I remember when we were learning this in school, I was reading like their definition for depression, their definition for bipolar, their definitions for, whatever else. And I'm like, oh my God, I have that. Oh my God, I have that. Oh my God, I have that. The idea is that in our world, we all probably have some aspect of some of these things, but now it's about whether it affects our activities of daily living and our quality of life. And that's when it really becomes this condition. And I could throw dysautonomia, depression, all of those things kind of into that same hat in that way, in that I think we all suffer with some of this, but when it starts to change the way you live, now it becomes something we need to address immediately. And especially when you throw a concussion on top of that, or you throw some of these other things on top of that, it can be really detrimental. So what is POTS? POTS is a little bit more specific, right? So POTS stands for Positional Orthostatic Tachycardia Syndrome. And so this is a little more specific, where dysautonomia can be bradycardic or, hyper heart rate or increased heart rate, tachycardic. This is where we have a little bit more specifically. This is almost always high heart rate, increased heart rate when standing up. That doesn't come back down. They're also going to have huge increases in blood pressure. That doesn't come back down. These are the patients. POTS really is a little bit more than lightheaded. Maybe they're really pre-syncable or darn near passing out. They're going to have more blurry vision, tunnel vision. But again, if you look at the symptoms, nausea, vomiting, fatigue, insomnia, shaking or tremors, sweating, difficulty thinking and concentrating, this is really from a lack of being able to get blood to the brain and being able to utilize that blood as a resource or fuel for the brain. And when that happens, again, you're going to have a whole bunch of symptoms that can result from that. So where dysautonomia maybe is just a dysfunction of how that autonomic nervous system is functioning, POTS is a little bit more specific. It's a little bit more dialed in. And there's actually a few more things that they will actually suggest for POTS or dysautonomia too. Um, Again, in general, 5, 10 years ago, this was almost always female patients. I can't remember a POTS patient that I saw that was a male before 5 years ago. But now I would almost say that it's not quite 50-50 coming into the office, but of the POTS patients, we've got way more male patients that are suffering with this than we ever have in the past. And again, I can put my tinfoil hat on and I can say, is it, the booster shots they had or vaccines that they had? Is it simply the spike protein? There's a lot of things out there. There's a lot of information out there that we could point it at. And some of that is necessary to know and understand too, right? Because we got to know, we'll talk about protocols later, but we've got to know whether or not we need to detox them from certain things or whether or not we need to address that with some protocols. But in general, we're starting to see a bigger shift of more males with this condition than just your female population. And again, not to harp on this, but just to bring it back to the forefront, whether, we always have had BC and AD before Christ or before the Common Era, and Anno Domini or the Common Era now. So BC or BCE and AD or CE. We need to really look at, before COVID and after COVID, however we want to letter those two things, because there is a clear line of demarcation. 2020 changed the conditions that were coming in the office. It changed the way people were presenting and how they were presenting. Like I said, there was, enough conspiracy theories to keep you busy for a while on why or what was going on there. And we don't need to address any of those kind of things, but it definitely was a change. There was definitely a difference now in how people responded after the fact and really how their brain and nervous system respond to various things, right? If you take concussion, like we've been talking about here a little bit, concussions are different now after this, whether they've been vaccinated or not. They're different as long as they had it. If you look at what I'm starting to see, if you look at where viruses hang out in the body, right? If herpes is a great example. If you had chicken pox when you were a kid, shingles is the reemergence of that, because that herpes virus never actually goes away. It just hides under something called a biofilm in your body, and it becomes what I would refer to as an opportunistic virus or an opportunistic infection. And you don't really get a reemergence of the chicken pox virus or the herpes virus until a lot of people get it when they're older. I know I had shingles when I was 18, and it was during a really stressful time in my life. So when we have stress, it kind of reemerges. But herpes reemerges at some very specific spots. A lot of people will get that painful rash around the outside of their chest. That's actually what I had. I've had patients that get it on the face. I've had patients that'll get it more vestibular and even vestibulo-ocular, meaning it affects the vision and also starts to get some dizziness and some issues there, but it's usually pretty predictable in those ways. I haven't heard of many other presentations than that, because what they found is herpes hangs out in the dorsal root ganglia of the thoracic nerves and of that vestibulo-ocular system as well, or vestibular nerve specifically, which then also affects the ocular system or the visual system. So it hangs out in a pretty specific place. And other viruses do that too. If you look at Lyme disease, if you work with that population at all, Lyme is another one that hangs out, hides under a biofilm, and then can present itself at different times, at different ways. If you've ever worked with Lyme patients, they're a lot like MS patients, like a relapsing, remitting MS patient, where you have a huge increase in symptoms, and then they might go away for a little while. It might go dormant for a little bit, and then another huge bout of symptoms, and then it might go away, or they might get better, or marginally better for a little while. And I think you see that to some extent with a lot of the chronic conditions, whether it's Lyme, whether it's mold exposure, whether it's MS. I think a lot of those can present like that in different ways. Well, we're seeing that with COVID as well. And the reason that I, address this slide here, or wanted to have this slide here, is we need to understand that. So every patient now that walks in, what I'm seeing is where COVID is hanging out is in that vagal system. And it doesn't necessarily just mean the superior parasympathetic, that inferior system as well, that sacral plexus is also where we're seeing it. You know, we're seeing some females with some dysautonomia POTS symptoms having urinary retention issues, and not post-pregnancy. These are females that never were pregnant and younger in age, because I think you're seeing this spike protein hang out in some of those areas. For whatever reason, you're seeing it in those parasympathetic system, or in that parasympathetic system. So it's changing the way that's able to function. And so again, like a herpes virus or something else that is more of an opportunistic infection that shows up at the worst possible time, right? When you're at your lowest, we're seeing the same thing with COVID. So now we're seeing maybe long COVID type symptoms accompany a concussion. You get this kid, Drew, that's in our office right now, who was doing pretty good, had a head injury or a hit to the head, and now he's showing up more like a POTS case, or more along the lines of dysautonomia, than he would a regular concussive event for a boy his age. There's a difference when you look at concussion in male and female athletes, and he's showing up more like a female athlete with those symptoms versus where we would normally see a male athlete come in. So there's always been some clear differences in that. Those lines are starting to blur a little bit, and I think it's because of that autonomic dysfunction that is just maybe part of the game now in this post-COVID era, or this era after we kind of have gone through this, and where that spike protein is now hanging out differently. Because I mean, at this point, we've all been exposed to it. Again, vaccinated, not vaccinated, we've all breathed in this spike protein at this point, and we're all affected by how it's going to bed down or lay down in our nervous system and affect our body and our physiology. And when you look at some of the data out there, this is out of the Washington Post. Dr. Lauren Stiles talks about how POTS and dysautonomia is on the rise, and really she's pointing the finger at the pandemic as well. Now, again, there's probably a lot more reasons, even than just COVID, for like the spike protein itself, for the rise in POTS and dysautonomia post-pandemic. I think there's a few different things, but even like she's saying, is she feels that the numbers at least doubled since the pandemic. And so there's a lot more of these cases out there, and no more doctors knowing anything about it. If anything, there's probably less doctors out there treating this and knowing anything about it. And their options are not really all that great for the POTS and the dysautonomia side of this. They just don't know what to do. They haven't recognized it for a while. I mean, shoot, 2 years ago, Mayo next to me wasn't even recognizing it as a condition. I have had patients that came in that were clearly POTS, like their heart rate laying down was 65 and standing up was 120, and they had seizures as a result of the drastic changes in their heart rate. But when they went to the hospital in an ambulance, they didn't notice anything wrong with their autonomic nervous system. And so it was about 2 years ago when Mayo finally started paying attention to it, because up until that point, there wasn't a lot of docs. There were certain neurologists, if you landed in the right office, that would recognize it and say, yeah, cool, we get this. But there wasn't a lot of them. And it's, again, it's kind of akin to Lyme. Up until a few years ago, there was a lot of doctors that didn't recognize Lyme as a disease. Even the WHO and CDC didn't recognize Lyme as a condition until fairly recently. And even now, I still don't think they give it the credence that it probably deserves for the amount of people that it affects on a daily basis. And I don't think they've quite paid attention to exactly how widespread some of that is. So we see the same thing with POTS right now, just because it isn't fully recognized by the allopathic medical community as a condition, as something that they can help and do something about. Even the ones that recognize it, like there's a neuro that we treat back and forth with quite a bit, and he recognizes POTS. He'll put the diagnosis on there, but he doesn't really have, and like he's even told me, he's like, I don't have a lot in my toolbox for this. There aren't any medications that it responds to really consistently, outside of sometimes they'll use some vasopressors and things like that to help with the blood flow part of it. But he said outside of that, metoprolol or things like that, they don't have a lot in their quiver, so to speak. So we need to be better, because something that this responds to really quickly is some neuroplastic changes, and really exercising the brainstem and exercising the prefrontal cortex, and really strengthening the body as well, because there's a lot of causes, like every disease, right? POTS, dysautonomia, they're multifactorial. And so we've got to treat those multiple factors if we really want to get changes in the system. And they're starting to drip out more information and more things on this topic very slowly from a medical standpoint, but also from a, I'll say, holistic practitioner standpoint. I think we've been on this a lot longer, so we've already got a lot more in our toolbox, so to speak. So why do we see this increase? Why is it doubled? And I think there's a few reasons. I think our world, I was talking to my dad the other day, and again, I'm not going to get into politics. Wherever you land, but I've never seen, I'm 45 years old, I've never seen an election that was this polarizing. My dad swears that there was one in the 60s that was about as bad. Um, I've never seen the country as divided as it is right now, at least on paper or in the news, however you want to look at it. Again, whatever side you're on, regardless of that, we definitely live in a polarized world. So there's a lot more stress. There's a lot more stress, not just because of that, but because we are, we're required to be more reachable in everything. The addition of smartphones, it's not that old. We're looking at like 15 years ago, 16 years ago, when Apple really hit the ground running with the iPhone. And there's no long-term studies of what that kind of accessibility does to the brain. We do know that it's a stressor. We do know that being available all the time, not having that time to turn off, is stressing our body and our brain in a different way than we've ever really known. So, and we're really only 15 years into this, so we can't do any long-term longitudinal studies because it hasn't been around long enough. So not only is there stress from the polarizing nature of our society right now, but we're required to be available, which is a stress. There's more media outlets with the smartphone. You're constantly being bombarded with what's going on or what's wrong. That wasn't a thing back in the day when I was a kid. Kids now at a younger age are more aware of everything going on around them than ever before. And again, because we live in the information age, information's not always good. Sometimes it can be stressful, and we're bombarded by that pretty constantly. Um, and as a result of that stress, you get this limbocortical windup, or what I've always referred to as limbic loops. Our amygdala, or our limbic brain, our survival brain, can become the dominant factor. It can start to wind up. And when it winds up, in the research, it's called amygdalar hijacking, or amygdalar windup. When that amygdala winds up, it takes blood and resources from the parts of the brain that make you human. Your prefrontal cortex loses resources, and your cerebellum loses resources. Those are the two most metabolically active parts of the brain. So those are the parts that suffer the most when you change function and divert blood and resources to other areas, like that limbic system or that limbic brain. So when this limbocortical windup occurs, we lose our control system, right? Your cerebellum balances and coordinates everything in your body, and your frontal lobe inhibits everything in your body. 90% of the output of your frontal lobe is inhibitory. But if you lose blood flow to that area, you lose the brakes. And specifically, you lose the brakes to the sympathetic nervous system. Your sympathetic nervous system comes out ready to go. That's the one that's on always. It's the parasympathetic that we have to engage to activate. Your sympathetic will be on if you do nothing. It's why babies, before they, as they're growing and developing, babies don't have a frontal lobe really, and they don't start developing the frontal lobe really until about 2, 3 years old when they get up and start walking around, driving the cerebellum. And your frontal lobe doesn't completely solidify in males till about the age 25. So that frontal lobe is supposed to be inhibitory in nature. When we lose blood flow to that, we lose that inhibition. That's why baby's heart rate before that frontal lobe has come online, a resting heart rate for a baby is like 120. It's not until they grow that frontal lobe that we start to get that heart rate under control more. And when we go in reverse of that and we lose that activation by the frontal cortex or the prefrontal cortex, then you'll start to see that sympathetic nervous system escape more. It's kind of a running joke with some friends of mine. I hate the term sympathetic dominance because your sympathetic nervous system will always be dominant. It's a sympathetic escape is more appropriate for what's actually happening neurophysiologically, because your frontal lobe is supposed to gate it or dampen your sympathetic nervous system. It's not about dominance or non-dominance. Your sympathetic nervous system is always dominant unless your prefrontal cortex can gate it. And when it's not gated, it escapes, and that's what allows that function or that elevated heart rate. And when the sympathetic nervous system is now ungated, it will dampen and inhibit the parasympathetic nervous system. So I just a aside for that term. Other things, again, long COVID, resting in that vagal system, I think is affecting a lot of this POTS and dysautonomia that we're seeing double the amount of now post-pandemic. We have blood volume changes and we're more sedentary than we've ever been because a lot of people are working from home and staying home. So even we don't think about this, but getting up, having to get out the door, get in the car, drive to work, walk from the parking lot into the office, and then sit in your cubicle is just a little bit more activity than rolling out of bed and going to sit on the couch and working from there. So, we're a lot more sedentary in our society now than we ever have been. And with the advent of technologies, again, not blaming technology or COVID for everything, but with the advent of these technologies, it allows us to do less and still get more done. But it doesn't allow us to do more physical activity. When we had to work in the fields and, go to factories and do all that kind of stuff before a lot of these things became automated, we were a lot more physical as a society. So as we become more sedentary, in our daily lives, you're going to see more of an issue with this because one of the ways that we do change blood volume to the brain is through muscles contracting. Veins don't have muscle in the wall, only our arteries do. And so in order to return blood back to the heart, we have to move to do that. And when we don't do that, you can start to get blood pooling. You get a decreased amount of blood back to the heart. Now you get a decreased ejection fraction, which now causes the heart to have to speed up to meet blood demands, but it's not getting blood back any more quickly. So now we end up with this elevated heart rate as a result, especially when we try to get up and move around because it's no longer able to meet the demands because we were lying down, right? So that's where we start to see this spin out. And if that happens enough times or we're sedentary long enough, then you'll start to see neuroplastic change in these pathways. You've heard myself and Dr. Cedarmark, we've talked about it in the past about whether or not neuroplastic change is always positive. Neuroplasticity, the ability to have neuroplasticity is always positive. But remember, your brain will get really good at whatever you tell it to do. If you tell it to be sad, depression can be neuroplastic change. If you tell it to become anxious and worried about everything, anxiety can be neuroplastic change. Well, this autonomic function can also be neuroplastically wound up. If all you do is lie around, then your brain's going to get really good at what you tell it to do. It's going to slow heart rate and blood flow, and it's going to change that function. And then when you try to get up after that, it's not going to know really how to do that. So we have to neuroplastically wire movement in. We have to be moving more purposefully in order to not have this negative neuroplastic change in our brainstem and other areas. Now, COVID can affect that neuroplasticity as well by bedding down in those neurons. And obviously, a head injury or a concussion can affect the function or the physiology in those areas too. So it's not just about being more sedentary. There's other injuries, insults, toxicities that can lend to this or lead to these types of things. But I think overall with COVID, we had a huge boon in the work from home sector, right? And I think that in and of itself really accelerated the sedentary progression or the becoming more sedentary. We were already going there, right? There was always already the things out there about sitting is the new smoking. And I think that boon really accelerated that change. So right now, the current paradigm for things like POTS dysautonomia, they don't have a cure. They tell you that straight up, at least over here at the Mayo Clinic. But really all they're doing is salt tabs. So they give people more salt, and it doesn't mean table salt, guys. I have this conversation once a day in my office. It doesn't mean put more Mortons on your hamburger. It's cell salts. It's things like potassium, magnesium, those types of things. Think more electrolytes. So they're giving them salt tabs or electrolyte tabs. They're using compression socks because if they're not moving, they need to compress the legs to get blood up from the legs to the brain. And I also said metoprolol is kind of the go-to from medical doctors as well. It's not on here, but you're starting to see, like I said, you're seeing things drip out. There's something called the CHOP protocol or modified Dallas protocol. CHOPS is Children's Hospital of Philadelphia, where they're having them do exercises, but they're doing exercises without elevation. So think like rowing machines. They're having them exercise their heart rate to about 110 and try to keep it there. So find a physical activity you can do at that rate and then allow it to come down, but nothing really long term. There's a clinic in the Cleveland Clinic they have a whole section or physical therapy wing devoted to this where they're doing different lifting things. It's mostly geared around things like deadlifts and squats and really strengthening the lower extremities, especially in the younger population, because we're seeing POTS now show up in like 10, 11, 12-year-olds, again, because of that sedentary lifestyle where they're not moving as much as they used to. A couple patient stories or cases that I did want to share with you guys, and this is going to be three different versions of this, right? We're seeing the POTS and the dysautonomia show up, but it's in three different cases. This first one, we'll say it's patient Jen, right? These names are kind of made up, but the cases are patients that we see in office. This is the one I was telling you about that kind of filled our office once we made changes with her. Diagnosed with dysautonomia or POTS 3 years before we got a chance to see her. We've been seeing her for a while now, but her regimen of compression socks and salt tabs and computer chair. I'll explain the computer chair in a second. That was really all that they gave her to do. And we live in Florida. So, she was in Michigan when they told her compression socks, which was fine. You can wear heavy things 9 months out of the year there. You try to wear compression socks here, you're going to die of heat exhaustion, especially for a couple months while we're in the middle of summer. So compression socks really weren't possible for her. And especially when you get into the older populations, they struggle to even get them on. So she was doing her salt tabs and that was helping a bit take the edge off, but really she got around on a computer chair. She would use a computer chair to get her kids off to school because she couldn't stand up and walk around, make lunches. She's got 3 kids. She couldn't stand up on a computer. She couldn't stand up to do that. So she would literally wheel herself around the house. She's a type A personality. I call her super mom because she does everything for all 3 of those kids, right? Even with POTS and the symptoms that she was having and not being able to stand, she still was able to get these kids off to school and do just about everything for them. She had a history of anemia too. That's another thing, like with female patients, they lose blood once a month. So with each one of her pregnancies, she actually was showing up anemic and had to do some iron supplementation. So that's another thing when you're looking at that metabolic component that can really play there. Her exam findings, obviously off the chart. She had an Apple Watch and measured her heart rate regularly, even before us. And her resting heart rate would go anywhere from 45 to 180. And she got around on a computer chair. So she wasn't like out running, but it would go to 180 just sitting in the car to go pick the kids up from school. So even those simple types of activities were really stressing her system and pushing her over the edge. So this is one case. This is what I would call your standard or your typical POTS dysautonomia case 5 years ago. And up until, what we've seen currently in the last couple of years, this was the norm. These were the cases. These were the only ones. And that's why I think we've seen a double in cases, is because you're seeing it more in males now too. But, Jen was your standard. I remember when we worked with her, she was getting around on that chair, not able to really get up. It was pretty quick. It was about 3 weeks into her care. She comes in and she's like, I got really dizzy the other day. I almost passed out. I'm like, really? Why? And she's like, well, I was lifting the kid's bed up to vacuum underneath it. And I was like, wait a minute, you were doing what? She felt good really quick, just with getting her adjusted, we worked with some food intolerances in her as well, getting some of those things taken out. Her system turned around really, really quickly. And I'm like, Jen, you realize like you got to go slow. You don't need to be lifting babies or kids' beds up to vacuum under them yet. Let's slow down a little bit. Um, but these patients, they need to do a lot more, and they want to do a lot more as soon as we can get that system turned on. But this was her current regimen, right? Salt tabs, compression socks, that's about it. And then, so this is the one that I was telling you guys about. This is something that we're seeing more of again with concussions. You're seeing these sensitivities or these changes. Every once in a while, we would get guys in with a concussion. When I was at Life, we worked with all the rugby guys, all the hockey players, all the sports and teams. And we would get a lot of the concussions that didn't get better after, their standard of 10 days in a dark room. And so they would send them to us and we'd work with them. And every once in a while, we'd get that male athlete in that had the elevated heart rate and some of the autonomic changes. But most of the time, with them, it was things like headaches, nausea with that population. We didn't get a lot of the light sensitivity and dizziness with them as much as we did with the female athletes. But we're seeing this more now in our male athletes. This is Drew, high school student. He's a high level athlete. He's a freshman playing on varsity. And his biggest symptoms are the light sensitivity. He just can't tolerate light. But the other thing that was kind of shocking to me was his resting heart rate of 107. Again, I don't normally see that. I knew him before this head injury. It's been a couple years since I've seen him, but his resting heart rate was like in the high 50s the last time I saw him. He's always been really, really active. The whole family works out regularly. They're very active people in general. And so for him to be sitting there in front of me with a heart rate of 107, that was alarming to me. And so we had to kind of jump into this, autonomic understanding. So when we lay him down, his heart rate goes down into the low 60s, high 50s. And then standing up, he's getting dizzy, he's getting wobbly. He almost the other day felt like he was going to pass out. And that heart rate goes really high. Immediately upon standing, his heart rate's going to like 130, 135, 140. And then it comes down to about 107 as long as he's vertical at all. So we're seeing this dysautonomic dysfunction. Now, his head injury too was landing on the back of his head. You get more from my experience, that's the worst head injury to have. You get more of the landing on the back of the head. It creates more of that hypothalamic shearing and that whiplash type of injury. Traditionally for me, the hardest ones to unwind have been those that have landed on the back of their head for the brain injury or for the concussion. And he's no different. He's a quarterback, so coming through, got driven down into the ground and landed like this, holding the ball, and smacked the back of his head and caused the traction in the brainstem area. And that's where we're seeing that hypothalamic shearing, the traction axonopathy that occurs in the brainstem, the pons and the medulla, and affecting a lot of that autonomic change. But he also, he's been through it with COVID. He's had COVID a couple times now after talking to him. And so I think that again is contributing here. Also the back of the head concussion part, but that autonomic change being the hallmark here. We're seeing more and more of this. And for him, we need to work on his neck strength too. That's something that he's a freshman playing varsity, and he already knows he's going to take 3 weeks off because, even if we get him ready to play, he's got 3 more years in high school to be able to do this thing. And so we need to strengthen him. His neck is pretty weak. He doesn't have the trap strength that's associated with decreasing the likelihood of a concussion. So we told him, like, we're going to get you back ready in probably a week, week and a half. And then we're going to take another week, week and a half to start to work on that neck and get you functional before we decide before we even start to talk about getting you back in. So, we've already sent a note to the coach saying he's out 3 weeks. We're going to do some strengthening, some concussion rehab with this, and really work on getting this kid up. And that was a conscious decision by his parents, really, and him, and not wanting to push back into it. Again, another male patient that we're seeing. COVID 6 months ago. He's had long COVID since, dizziness when standing, brain fog. This is what we're seeing in the male patients, different than the female patients. And I think this is the long COVID dysautonomia finding that in males has been really weird. And I'm just referring to them as heart zaps. He calls them heart palpitations, or he says, I get this funny feeling right around here. And it's usually when he's laying down, about to go to sleep, or when his system's finally starting to relax, and he gets this this heart zap or this jolt awake. And then he's like, my heart's racing after that. And it jumps up. He doesn't have a pulse ox at home, but when he's had him here, we'll have him lay down and relax a little bit, and he'll get one here. And the heart rate laying down goes to like 120 after, it was 70 or 65 lying down. And so we're seeing it's something that I haven't had a female patient report that yet. Not that it's not happening in them, but this is the third male one that I've seen in the last 6 months that reports that same thing, that like heart zap type of sensation that goes along with their dysautonomia. Now, he again has some other issues. He was seeing an upper cervical chiropractor that was talking about potentially having Eagle syndrome because he had an elongated styloid process, they thought maybe on imaging. That's been ruled out now. So there's no compression on the jugular vein or any of that kind of stuff. Almost everything that he's coming with is more the POTS and dysautonomia type stuff. So where we've jumped in with him, the biggest change for him actually, that's different than Drew. We haven't actually worked Drew back in with exercising yet. That starts next week. But the biggest change with Aaron is that we've actually started him doing just kettlebell stand-ups, and I have him doing them while he's watching TV. So, and this is something I've done in the past with other male patients too. We have him just doing, he's got a kettlebell at home. It's 25 pounds that he stands up with and sits down on commercial breaks. And that's about all the physical activity he can handle right now. But he's been able to go from about 5 or 7 of those to where the last time I saw him, he's gone the whole commercial break. So for a couple minutes, standing up, sitting down, he's like, I think I did about 20 or 25 yesterday. So he's able to have more longevity in that activity. And then once he gets able to do that pretty consistently, we'll start to work in more of the CHOP protocol. So have him doing some things like row machine and some of those other things to really work in some of that physical activity. But at the same time, we're doing a lot of stuff. We've got him gargling at home to really activate the brainstem and the vagal system. We have him doing in all 3 of these patients. Pencil push-ups is a big part of what we do with them to work on that convergence and divergence, which is done in that mesencephalon area, which works on gating and helping to control those autonomic areas. And then you'll see a little bit of a difference in how we approach the male and female. So where do we start with them? We do a lot of things in our office. Vagal stim is a big one. Again, is it active or passive? Passive is we have a little tongue stim device that we use in our office that we can stimulate their vagal nerve with. There's a lot of other vagal stims out there, whether it's a carotid vagal stim or other versions of that. There's devices like the Pons device or the Lanier device that are tongue stims that they can get for home. They're expensive, like 5 or 10 grand, but those are other devices that they can use. But if you Google vagal exercises, there's a million of them out there, right? But stimulating the vagal nerve in some way, shape, or form. Exercise is a big part of what we've got to get them to fairly quickly. Like I said, with Aaron, it's kettlebell stand-ups. With Jen, it was kettlebell stand-ups too, was one of the first things that we did. And the reason we do the kettlebell stand-ups, and we have them do it very specifically, when they're seated in a chair, we have them grab the kettlebell, and then they have to contract their abdomen first before they stand up. So we work on the control of the middle of their body or their shunt stabilization system before they activate the legs, which would be considered spurt muscles. So we have them really almost like a Valsalva maneuver before they stand up to work on sending blood to the brain. And that's how we neuroplastically rechange that pattern, right? They're used to seated or sedentary. We need to change the brain's ability to move blood, but give it a cue as to when to move the blood. And that giving them that cue, like that vagal response or that, not vagal, that Valsalva response tells the brain, hey, I'm getting ready to move. I need to do this. So you need to start moving blood, and it'll constrict some of the blood vessels, the arteries, and start to move blood more where we need to go. But we've got to make those legs bigger because the muscles in the legs are going to be what pump the venous return blood back up to the heart. We can have some visual and vestibular activities here, especially with Drew. Because of the concussive part of this, we're going to work through the visual system more so for his dysautonomia type findings, because I would also do that for a concussion patient, right? So we need to be more visual vestibular with him. We'll put him in the gyrostim chair behind us and work through some of that with all of our patients with the dysautonomia and POTS. I do a lot of that. Whole body rotation, again, starts to train them how to move blood around their system through that vestibular system. The vestibular system, if you remember, is the most primitive part of your nervous system in your brain. And when it develops, it starts to grow other areas like the prefrontal cortex and the cerebellum, the vestibulocerebellum. And so it helps with the integration of those parts really well. So we do a lot of, if you don't have a gyrostim, spinning them in a computer chair is a great way to do it. There's some patients that never make it into there. I just spin them in the computer chair because it's just easier, it's quicker, and they get a great result out of that. So we have them do a lot of vestibular type activities. We can have them do some ×1 movements like yes, yeses and no, nos, any of those to start to integrate that movement part of their brain to start to move blood around the system. And don't forget about activation of the prefrontal cortex to inhibit that brainstem, right? Your frontal lobe, 90% of it is inhibitory through areas like the PMRF or pontomedullary reticular formation. It's going to inhibit autonomics. It inhibits flexors to allow us to stand upright, and then it inhibits that autonomic or specifically sympathetic system to control things like heart rate. So we've got to make sure we engage that prefrontal cortex and really activate that system to have an inhibitory effect. So not only do we need to rehab the neuroplastic change in the brainstem to know when and how to move blood, but we've got to make sure we're changing the neuroplasticity or the activity in that prefrontal cortex to draw blood and resources back to it to be able to inhibit that stuff at rest and more regularly for us too. And this is one part that I want to hit on too with these differences in population. Remember that you won't do the frontal activation the same for your female patients as you will for your male patients. Now, yes, across the board exercise is good, but females are going to be more verbal. They're more cognitive. Males are typically more physical. So with guys, it's more important to get into the weights, to moving the weight around. Whereas females, we always jokingly say like the number one exercise for our female dysautonomia patients is to grab a girlfriend and go for a walk. This should move as much as the legs do. And so they're moving, they're still getting that movement, but we want them to be able to talk out their stressors to get out of that limbocortical activation and more cortical. And they need to be more verbal in order to do that. Guys can, because of testosterone differences versus estrogen, we tend to want to be or crave more of the physical activity. So the guys might do working out more, like I said, with Aaron and with some other people. We've done the kettlebell sit-ups during commercial breaks. I wouldn't necessarily do that with a patient like, say, a Jen or something like that. So we're able to get a little bit of a different activity in that. Make sure you're addressing that or at least paying attention to it. Your female patients, they tend to run more towards anxiety. Your male patients will run more towards depression. Make sure you're paying attention to that. Talking it out is a better thing to do for that anxiety, understanding that it's not such a big issue. So we pay a lot of attention to that. In addition, like I said, in our office, we do quite a few things. We're going to use things like NET or EMDR to address the limbocortical component. If that isn't something that's in your wheelhouse, refer it out. I have a lot of friends that just don't want to get down in the mud with that, and they refer that out. We make sure we're feeding the brain too. As a general rule, when we're dealing with dysautonomia concussion, we take everybody off of gluten, dairy, and soy. They're neuroinflammatory. So we really need to decrease that neuroinflammation and slow that down. We deal with a lot of food sensitivities and things of that nature too. So we pay attention to what those foods might be, and we might remove those in addition to the gluten, dairy, and soy. Something that works really well with these patients is what I refer to as tilt table work. We don't do it in a tilt table. We actually do it in a zero gravity chair. So we have them lying down where their heart rate is low, and then we slowly bring them up until we see the heart rate start to creep up. And then we do all sorts of frontal and brainstem activations there. So for us, we might stimulate the tongue. When I don't have that, I'll do some like horizontal eye movements or some saccades or frontal activation type of activities. Sometimes what I'll actually do is just put pressure in the abdomen, which mimics digestion of food, and you'll see that drop the heart rate. So basically, as you're working them through these different planes in a zero gravity chair, or if you have like a zenith high-low table, even better. As you're working them through those planes, you're trying to find a way to lower the heart rate every time it starts to creep up. And so that's been a big hallmark. We always like, if I had to give you a protocol, I would say adjust them and then tilt table and then exercise their legs. Like those are the three things across the board that we do with our patients. So we adjust usually upper cervical, occiput, C7, maybe lungs, I'm sorry, maybe ribs for the lungs and respiration because it fires into those pneumotactic and those cardiopulmonary centers. And then we're going to work on vagal stimulation through a plane of motion, starting with them as parallel to the ground as we can, and then working slowly until we start to see that heart rate go up, i.e. the tilt table protocols and tilt table work. And then if we can, if they can tolerate it, or as soon as they can tolerate it, we're going to exercise the lower extremity, whether it's kettlebell stand-ups or whether it's, even just something like ankle pumps or vibration platform or things of those nature to start to strengthen those muscles to be able to pump blood better. Because that's the biggest thing is they need to have better control of blood flow so that the heart can slow down so it doesn't feel like it needs to keep up with an ever demanding situation. Because that's where we're getting to with these patients is they don't have the ability to move blood back to the heart. So the heart feels like it's got to pump more quickly and it's just kind of never going to be able to catch up that way. We need to cut out the sedentary. We need to improve the blood flow back to the body in whatever way that you can do that. And it's not to say we don't use some compression socks for a little while until we can get that neuroplastic change in, or especially early on while we're working with them. I still promote the socks and we use salt tabs a lot, but we need to make changes in that brainstem and that prefrontal along with that. So that's my spew or spiel on the dysautonomia, POTS, and concussion, and how we're starting to see some similarities in that. Hopefully you guys enjoyed this. I always enjoy talking to this group with IAFNR. It's awesome having such a difference in the types of practitioners that are taking this class. And that's one thing that always drew to me to IAFNR is that it's very multidisciplinary, right? A lot of times as chiropractors, if we sit in a room, it's all chiropractors, it's all completely like-minded individuals, which is great to an extent. But I really love that we're bridging this in and Janice and Gia have both done a phenomenal job in marketing this with groups like Sourcey and other ones to really pull in different types of people because the world needs help. They need this type of help now more than they ever have. And with groups like IAFNR, with some of the, founding fathers of it, they've been setting this precedent from the beginning. I'm just fortunate to be a part of this and try to continue to drive this. But, Dr. Janice and Dr. Gia have done a phenomenal job in putting these things together and getting this out there, getting the word out there. And hopefully you guys enjoyed this. If I can be a resource to you guys in any way, shape, or form, if you have any questions, this is my email address and our website. Feel free to reach out to us any way that I can help or be there for you guys. We are willing. Thank you guys and enjoy the rest of the conference.